Welcome, future surgeons, to another deep dive. We've all been there, haven't we? You're facing a patient, maybe it's for the MRCS, that big exam,
Mm.
and you need to nail that knee examination.
Oh, absolutely.
It can feel a bit overwhelming, like you're just going through a checklist, but it's more than that, right? It's about understanding why you're doing each step.
Exactly.
So today, our mission is clear. Cut through the noise, give you a really actionable map for the knee exam. We want you walking away feeling confident.
That's the plan.
Yeah.
And, the good news is, while it seems complex, the knee exam follows a very logical pattern, like any joint, really. We'll break it down. Look, feel, move, and then the special tests. Simple pillars. But before anything else, the absolute basics. Can't stress this enough.
Go on.
Introduce yourself properly, wash your hands, obviously, and then immediately, before you even touch the patient, ask that crucial question. Do you have any pain anywhere?
Right. Sets the tone, avoids causing unnecessary discomfort.
Essential.
Totally essential. Builds that trust right from the start. Okay, stage set. Now let's imagine that patient walks in. Maybe an athlete, maybe someone older with stiffness. Before you even get hands-on, it's all about observation, the look phase. What are those first things you're clocking? The broad strokes.
Yeah, think like a detective scanning the scene. Look around the patient first. Any walkie aids, crutches, a stick, shoe raises.
Clues, right. Tells you about their mobility.
Big clues. Then look at the patient overall. Are they well, unwell, seem comfortable or clearly in pain? And then, critically, you ask them to do something.
Ah, the dynamic part.
Exactly. Ask them to walk a few steps. Then if they can, ask them to squat. It gives you such a quick functional snapshot. You see guarding, limitation, asymmetry straight away. It's surprisingly revealing.
That makes sense. A real-time functional assessment before you even focus on the joint itself. Okay, so after the walk and squat, you zoom in on the knee while they're standing.
Precisely. Now your focus narrows right down. You're scanning systematically. General things first. Obvious swelling. Muscle wasting. Look really closely at the quads, especially the VMO, that inside muscle.
That's often the first to go with knee problems.
It really is. Also look for redness, warmth signs of inflammation, any sinus tracts. That could mean infection, something deeper.
Okay, general signs noted. Then you look from specific angles.
Yep, break it down. Anterior view first, legs together, checks for scars, old surgeries. Again, quad wasting, sinuses. Any fixed flexion deformity where the knee won't go fully straight, or other deformities.
And alignment. Valgus, varus.
Crucial. Knock knees or bow legs. It's not just cosmetic. It tells you about long-term joint stress, maybe predisposition to arthritis. It's a really important piece of the puzzle early on.
Got it. So anterior covered. What about from the side, the lateral view?
Lateral view, again, scars, muscle wasting, sinuses. But this view often gives you a much clearer picture of any fixed flexion deformity. You see the profile.
Makes sense. And posterior. What are you looking for from behind?
Posterior. Mainly scars again, and importantly, popliteal swellings. Things like a Baker cyst, easy to miss from the front or side. That swelling could indicate chronic fluid or something else going on back there.
Okay, that's standing covered thoroughly. What changes when the patient lies down supine? Are there things that become clearer then?
Yes, definitely. When they're supine, gravity helps, muscles relax. Now, you look really specifically for effusion fluid in the joint, the classic sign.
The horseshoe swelling.
Exactly. That horseshoe swelling around the top of the patella in the suprapatellar pouch. It's a really strong visual clue for fluid. And this is also a great time to get a really good look at scars again.
Especially those little arthroscopy ones.
Precisely. Those small puncture scars, usually either side of the patellar tendon, anteromedial, anterolateral, they instantly tell you about previous keyhole surgery. Invaluable history right there.
It really is amazing how much you can gather just by looking carefully. Sets the foundation. But okay, let's get hands-on. Moving to the feel phase. You already asked about pain. So what's the systematic approach once you start palpating?
Absolutely. Keep communicating. First touch. Back of your hand to assess temperature. Compare it to the other knee or the thigh. Increased warmth. Think inflammation, maybe infection.
Simple but important.
Very. Then, if you saw quad wasting during inspection, now you measure it. Standardized point, 15 centimeters up from the tibial tubercle. Measure the circumference.
Why that specific point?
Consistency. So your measurements are reliable, comparable over time, or if you're talking to colleagues. You also want to actually feel the quad bulk. Ask the patient to push their heel down into the bed, activating the muscle. Feel the tone, the substance.
Assessing strength dynamically, too.
Yeah.
Nice. What about that fixed flexion deformity, confirming it?
Right. Gently slide your hand behind the knee into the popliteal fossa. Does the knee lie flat on the bed? If not, there might be an FFD. To see if it's truly fixed, put one hand on their patella, the other on the quad muscle, and gently try to straighten the knee fully. This helps tell if it's a fixed contracture or just, say, hamstring tightness.
Okay, now effusion. We saw the horseshoe sign, perhaps, but feeling it gives more info, right? Especially the amount of fluid. How do you assess different sizes? This trips people up.
It does, but it's systematic. Think small, moderate, large. For small effusions, the swipe cast, knee extended. Stroke firmly up the medial side, milking fluid up into the pouch. Then a quick swipe down the lateral side. Watch closely. Do you see a little fluid bulge reappear on the medial side?
Like a ripple.
Exactly, a ripple or bulge. Also, look for loss of that normal little hollow, the medial sulcus. It's subtle, needs practice, but picks up small amounts.
Got it. What about moderate effusions?
For moderate, the patellar tap test. Again, knee extended. Use one hand to push down firmly above the patella, emptying the suprapatellar pouch. Then with your other hand, use your index finger to push the patella sharply downwards towards the femur.
And you feel...
If there's enough fluid, you'll feel a distinct tap as the patella hits the femur and bounces back out, like tapping a floating object.
clear and large effusion.
For large ones, the cross fluctuation test. You're basically balloting the fluid side to side. Apply pressure on, say, the medial aspect, and feel with your other hand for the fluid wave bulging out on the lateral aspect, and vice versa. It's quite obvious with a large effusion. Differentiating these sizes matters tells you about severity, potential causes.
That's super clear, breaking it down by effusion size. Okay, beyond fluid, what about finding specific tender spots? How do you systematically palpate around the joint?
Systematically is key so you don't miss anything. First, flex the patient's knee, maybe around 45 degrees. This relaxes things, opens the joint lines a bit.
Makes palpation easier.
Much easier. Then methodical palpation. Start medially.
Yeah.
Feel the medial tibial condyle, then the medial joint line itself, really important, then the medial femoral condyle, and trace the medial collateral ligament. Move down to the tibial tuberosity.
Okay, covering the inside.
Then go posteriorly. Feel into the popliteal fossa for tenderness or masses. Then swing around to the lateral side. Lateral femoral condyle, lateral joint line, lateral tibial condyle, lateral collateral ligament, and finally, the head of the fibula. Cover all the bases.
Right, a full circuit.
Exactly. Then straighten the knee again. Now focus on the patella. Palpate it, gently moving it side to side and up and down. Feel for crepitus, that grinding and tenderness underneath or around it. That points to patellofemoral issues.
And anything else in the feel phase?
Yes, two more things. Palpate along the whole extensor mechanism, quad tendon, patella itself, patellar tendon. Feel for any gaps or defects. That could mean a rupture. And finally, don't forget to check for popliteal lymph nodes in the fossa. Enlarged nodes could suggest inflammation or infection nearby.
Okay, comprehensive feeling done. We've looked, we've felt. Now let's see how this knee actually works. Time for the move phase. What are we assessing here beyond just, how far it bends?
It's about the quality of movement, the function. As they start moving, rest your hand gently on the knee. Feel for crepitus, that grinding or clicking. It can suggest arthritis or maybe meniscal problems.
Feeling during movement.
Exactly. Then ask the patient to actively flex their knee. Bring your heel towards your bottom as far as they can. Normal is usually 0 degrees, fully straight, up to maybe 150 degrees of flexion.
And passive movements.
Crucial. At the end of their active flexion, gently try to push it a little further passively. This tells you if the limit is true stiffness, a mechanical block, or if it's just pain stopping them. Big difference.
Makes sense. What about extension?
Right. Assessing the extension apparatus. Check again for any fixed flexion contracture. Then, the straight leg raise test. Ask them to point their toes up, lift the whole leg straight off the bed, then lower it slowly.
What are you looking for there?
You're looking for extensor lag. Does the knee droop slightly, fail to stay fully locked straight as they lift? That suggests weakness or a problem with the quad mechanism. Finally, check for hyperextension or genia recurvatum.
How do you do that?
Gently place one hand on their patella. Use the other to lift their heel off the bed. Does the knee sag backwards, extend beyond straight? That could indicate ligament laxity.
Okay, movement covered. Now for the real detective work, the special tests. These are the specific maneuvers targeting ligaments, menisci, the patella. Where do we start with these?
Let's start with the stabilizers on the sides. The collateral ligaments, you do the valgus and varus stress tests.
Okay.
Patient lying supine. First, with the knee fully extended, tuck their ankle securely into your armpit, gives you good control. Then use both hands on the knee to apply an outward force that's valgus stress, testing the medial collateral ligament, the MCL. Then an inward force varus stress, testing the lateral collateral ligament, the LCL.
Feeling for
Any gapping, any excessive opening up of the joint line compared to the other side, or pain. But don't stop there. Repeat the whole thing with the knees slightly flexed, about 20 to 30 degrees.
Why test inflection too?
Because flexing unlocks the knees slightly, takes bony stability out of the equation, and isolates the ligaments better. You might pick up laxity in flexion that you missed when it was fully extended.
Right, crucial extra step. Okay, collateral's done. Now, the big ones inside the cruciates, ACL and PCL. What are the key tests here?
3 main ones. First, super quick and easy, the posterior sag test. Have the patient lie supine, hips flexed, knees bent to about 45 degrees, heels together on the bed. Just look from the side.
What are you looking for?
Does the tibia, the shin bone, visibly sag backwards compared to the femur? If it drops back, that's a strong sign of a PCL tear. Simple observation.
Okay, sag test first, then.
Then the drawer test. Keep the patient in that same position, knees bent to 45. Now you sit gently on their feet to keep them stable. Wrap your hands around the top of their tibia, thumbs on the front, fingers behind. Now gently pull the tibia forward and push it backward.
Anterior and posterior draw.
Exactly. Too much movement forwards suggests ACL laxity. Too much movement backwards or starting from a sagged position suggests PCL laxity.
Got it. And the third one, Lachman's.
Yes, Lachman's test. Often the most sensitive, especially for acute ACL tears. Now you flex the knee just slightly, maybe 20 degrees. One hand stabilizes the lower thigh, the femur. The other hand grips the upper tibia.
So one hand holds, one hand pulse pushes.
Right. You pull the tibia forward while pushing the femur back, then reverse it slightly. You're feeling for the endpoint. Is it firm, like hitting a solid stop? Or is it mushy, soft, with increased forward movement compared to the other side? That soft endpoint is classic for an ACL tear.
Okay, those 3 sag drawer Lachmans give you a really good picture of the cruciates. What about the menisci now? Those C-shaped shock absorbers, how do we test them?
For the menisci, the go-to is McMurray's test. It's designed to try and trap or pinch a torn piece of meniscus.
How's it done?
Okay, 2 parts. First, to test the medial meniscus, fully flex the patient's knee. Then externally rotate their foot tibia. Now, while keeping that rotation, slowly extend the knee.
Feeling for what?
You're feeling and listening for a distinct click or clunk along the medial joint line. And crucially, ask the patient if it reproduces their pain. Then for the lateral meniscus, fully flex the knee again, but this time internally rotate the foot tibia, then slowly extend the knee, feeling along the lateral joint line.
Same thing, looking for a click and pain.
Exactly. A palpable click combined with focal pain during the maneuver is quite suggestive of a meniscal tear in that compartment.
Okay, McMurray's for menisci. Finally, the patella itself. Any specific tests for kneecap problems like instability?
Yes, the main one is the lateral apprehension test. This is key if you suspect the patient's patella dislocates or feels unstable.
How does that work?
With the patient relaxed, knee extended or just slightly flexed, gently push the patella sideways, laterally with your thumbs on the medial edge. Maintain that gentle lateral pressure and then slowly start to flex the patient's knee towards about 30 degrees.
And you're looking for...
You're watching the patient's face very closely. Do they suddenly look worried, apprehensive? Do they try to stop you? Or does their quad muscle tense up involuntarily?
Ah, so it's their reaction, not just how far it moves.
Precisely. If they look scared or guard strongly, that's a positive apprehension sign. It suggests they feel like the patella is about to pop out, indicating instability. You're not trying to actually dislocate it, just assess their response to that directed pressure during movement.
Wow. Okay, that really walks us through the whole process. Look, feel, move, special tests. It's such a clear, logical flow when you break it down like that. It's obvious how each step builds on the last to create that full clinical picture.
Absolutely. It's not just a list of things to do. It's a narrative you're building about that knee. Each finding informs the next step, guiding you towards a likely diagnosis.
That's so true.
And, we've laid out the steps, but like any skill, real mastery comes from doing it over and over. Practice, refinement, really paying attention. It's not just ticking boxes. It's keen observation.
Understanding the why behind every move.
Exactly. Understanding what you're looking for, what you're feeling for, what that specific test is actually testing. So maybe a final thought for everyone listening. Beyond just performing all these steps, think about this. In a busy clinic, new patient, knee pain, what single observation or test do you think is most critical for quickly ruling out a really major time-sensitive injury?
That's a good question to ponder.
Keep that curiosity going. Keep practicing, keep observing. That's how you really hone those clinical skills.